Hello to everyone. We welcome you to our session today. So this is session 2 of the oxygen therapy and critical care, the case-based series. And we are going to be discussing on the diagnosing of hypoxemia and pulse oximetry. And today, our panelists are going to be Dr. Papytcho, as it was in the last session from Livingstone Central Hospital, Dr. Hope Firi from Maina Soko Military Hospital. Also, we are going to have Dr. Sipu Kandaba from the University Teaching Hospital and Dr. Eric McDaniel from the University of Minnesota. So these are going to be our panelists today. To share a little bit on the project Eco Etiquette and housekeeping, I would like to remind everyone that our programming is based on the foundation of love and respect. Please respond kindly rather than react if you disagree with something. It is everyone's responsibility to keep the webinar a safe space. We will be using the chat function for question and answer at the bottom of the screen. Please send all your questions through the chat box and feel free to introduce yourself. Please turn on your video and position your webcam effectively to show your face if you're alone or to capture the whole group if you're in a group. If you have any IT issues, send a message through the chat to the Eco IT. Also remember that the session is being recorded and your attendance is consent to be recorded. Thank you, and please also be mindful of infection prevention and control and try to limit numbers of people joining from more than one gathering place and practice physical distancing. After that, I would like to hand it over to Dr. Papytcho and the panelists to continue with the session. Please welcome.
Thank you very much, Kevin. And thank you all for joining us on today's session. It's a continuation of the previous class we had the last 2 weeks. This one, we are talking about diagnosing hypoxemia with pulse oximetry on our patient who came to our emergency room presenting with chills, weakness, and a dry cough. Our practice improvement objective of today will be to understand how to use a pulse oximetry during COVID-19 pandemic and understand and recognize pulse oximetry latency, to select and rank oxygen delivery devices by FI2 delivery, and use the live box triage tool to select the most appropriate oxygen delivery available. And then the other practice improvement objective is use non-invasive oxygen delivery devices and assess the type of oxygen supply at your facility. To list the conditions that interfere with accurate pulse oximeter readings and to learn how to clean and maintain the pulse oximeter device after use. So these are our practice improvement objectives. We believe that by the end of this session, we should be able to acquire this knowledge and put them into practice. So our case update, as we said earlier on, in part 2, we learned that the 57-year-old male who came presenting with a 4-day history of chills, weakness, and cough, his wife, who was a nurse, tested positive for SARS-CoV-2 3 days before that. His SpO2 reading was 89 at home, so his wife sent him to the emergency department for further treatment. At the hospital, the patient was screened for COVID-19 risk factors. He was isolated from other patients and is wearing a face covering. You and the nursing students are wearing PPE for contacts, droplets, and airborne precautions. The patient admit is short of breath with moving and eating, but denies fever, shortness of breath at rest, loss of taste or smell. He states he has been less active and staying in bed. When you check the vital signs, the heart rate is 95 beats per minute, the blood pressure is 95/52 millimeters of mercury, respiratory rate is at 24 beats per minute, the SpO2 is 89%, and the temperature 36.5. You recognize right away we recognize right away that the patient is hypoxic and started him on oxygen by nasal catheter. Kevin, can you go up, please? Thank you. At 5 liters per minute as a flow. So his SpO2 initially improved to 97%. So we've realized that after initiating oxygen therapy through nasal catheter, the SpO2 has improved from 89 to 97. And the flow at which the oxygen was given was 5 liters per minute. So here the question you might want to answer is to know how is pulse oximeter used in the COVID-19 pandemic. To answer this question, I have other panelists on board who will come in and make some comments on how the pulse oximeter can be used. Kevin, please, can you click the... Thank you. So we have a video that we're gonna watch. This is a long video of 8 minutes, 45 seconds. We might not have enough time to run through the whole video. So we can just watch parts of it for some few minutes and then we'll come for further discussion.
This video shows the use of a pulse oximeter in the context of the COVID-19 pandemic. Severe COVID-19 primarily affects the lungs. Measuring oxygen saturation is essential for deciding when to use precious oxygen resources during the pandemic. A pulse oximeter is used to measure oxygen saturation and can help identify severely ill patients who should be hospitalized and receive oxygen therapy. Please note, available oxygen, flow rates, and administration practices will vary according to local protocols and resources. Make sure you know what kind of oxygen. Note, available oxygen, flow rates, and administration practices will vary according to local protocols and resources. Make sure you know what kind of oxygen therapy is available in your institution, how it can be delivered, and what local guidelines are in place. Do you need to measure your patient's oxygen saturation? You will need to decide whether your patient should have their oxygen saturation measured. To decide, you will need to ask 5 questions. 1. Does your patient have a fever? 2. Does your patient have a cough or difficulty breathing? 3. Does your patient have an increased respiratory rate? 4. Does your patient have any emergency signs, such as obstructed or absent breathing, severe respiratory distress, central cyanosis, shock, coma, convulsions, or uncontrolled vomiting? 5. Is your patient being admitted as an inpatient? Fever. Any known fever over the last 14 days is an indication to measure oxygen saturation. Cough or difficulty breathing. Any cough, difficulty with breathing, or shortness of breath over the last 14 days is an indication to measure oxygen saturation. Difficulty breathing can be any abnormal breathing pattern, including but not limited to breathing too fast, too slow, too deep, noisy breathing, labored breathing, or any pain or discomfort associated with breathing. Increased respiratory rate. An increased respiratory rate is an indication to measure oxygen saturation. This is a little more complicated than the other reasons to measure saturation, as normal respiratory rate varies with age. Let's spend a little time here reminding ourselves of abnormally high respiratory rates in different age groups. In adults and children 16 years of age and older, a respiratory rate of 22 breaths per minute or more is abnormal. In children 5 to 15 years of age, a respiratory rate of 30 breaths per minute or more is abnormal. In younger children from 1 to 5 years of age, a respiratory rate of 40 breaths per minute or more is abnormal. In infants 2 to 11 months of age, a respiratory rate of 50 breaths per minute or more is abnormal. In neonates and very young infants up to 2 months of age, a respiratory rate of 60 breaths per minute or more is abnormal. Any patient who has an increased respiratory rate should have their oxygen saturation measured with a pulse oximeter. Emergency signs.
Alana, thank you.
Emergency signs are an immediate indication for admission and resuscitation, including administering oxygen therapy. Resuscitate, administer oxygen, and measure the patient's oxygen saturation if any of the following signs are present. Severe respiratory distress. Signs of severe respiratory distress can include obstructed or absent breathing, head nodding in younger children, nasal flaring, grunting, usually in younger children, tracheal tugging, intercostal retraction or inward pulling of the skin between the ribs during inspiration, and deep lower chest wall indrawing or inward pulling of the skin below the ribs.
Anna, thank you very much. We can give opportunity to Dr. Ndaba to make a comment. The video is quite long. We just encourage our participants to go online and view the whole video and download it for further use. So for now, please, we go back on the same slide. The previous question. Yeah, we can click the same question. Yeah. Yeah. Thank you. There comes a tool on how to make diagnosis and do a triage based on the pulse oximeter. So I can call out Dr. Ndaba to make some few comments how the tool can be used and how to come up with a triaging strategy.
Hello, thank you so much, Dr. Papytcho. I hope you can all hear me clearly.
Yeah, you are clear.
Okay, thank you so much. Yeah, so as we have seen from the short video, a pulse oximeter has become one of the most important devices or tools that ideally every facility needs to have. And in the era of COVID-19, it has become a very, very essential device that we all need to know how to utilize it, because it helps us to decide on, in the triage setting, on which patients will require oxygen. It also helps us to determine the severity of COVID-19, as well as other emergency conditions that a patient would present with. It also helps us to monitor response to oxygen therapy. And the fact that it's a non-invasive tool, it's simple to use, it can be used on anyone at any time, regardless of the age. It's something that we all need to know and we all need to have as we take care of these patients. So again, as we heard from the short clip, we saw that we need to measure the oxygen saturation on virtually every patient that presents to our facility, but more specifically, those that to present with specific signs and symptoms on initial assessment. So in a setting like triage or any clinical setting, you need to measure the SpO2 in patients that will present with a fever, for instance, any patient that will present with chest symptoms such as a cough, shortness of breath, or increased respiratory rate. And so a pulse oximeter, it's a device that we need to make sure that we all have, and we use it in a clinical setting to help make decisions regarding the severity of the condition of the patient, as well as which patients will need oxygen, as well as monitoring the response to therapy. Thank you, Papytcho.
Thank you very much, Dr. Ndaba. Thank you for the nice summary. I will also take this opportunity to encourage our participants to download this and stick it in the emergency room. It could be of help when assessing patients and easy to make up decisions. Just after this, there's another short video. You see, after using a pulse oximetry from one patient to another one, we have to know how to take care of the pulse oximeter. Alana, we are still on the same question, please. The next video on how to clean the pulse oximeter. Thank you. Just below this. Yeah, so the video is too short, and then it's giving us instruction how you can use to clean a pulse oximeter after being used on the COVID patients.
Between patients, it is essential that you gently clean the probe and cool it with medical alcohol. Small amounts of 70% alcohol-based hand rub will also work, but should be applied sparingly. It's important to keep the LED and photo detector clean. Please also remember to wash your hands, following proper protocol between patients. The oximeter should be wiped down regularly, using common detergent and non-corrosive disinfectant, such as those used in hospitals. Be aware that many kinds of detergents must be diluted prior to use. The oximeter case and screen can be wiped with a lint-free soft cloth or a sponge moistened in detergent. While cleaning the oximeter, be careful not to spill liquid onto the instrument, and do not allow any liquid to spill inside the oximeter. When wiping the side panel of the oximeter, be especially careful to keep liquid away from the cable and the outlet.
Thank you. Those were clear instructions that we received. You know, as a user of pulse oximeter, we have to take care of our equipment that we utilize. Otherwise, if we don't take good care of it, it can be a source of post-infection from patient to another one. So knowing how to clean and what to use is very important. Yeah. Remember from the first session, we had a student who really wanted to know more about some decision that you as a clinician you're taking. She was quite inquisitive. She asked many questions. She was asking like, how do you make decision when to change the oxygen delivery devices? When do you make decision to increase flow of oxygen? How long does it take for it to change on the reading to change on the pulse oximetry? And so many other questions. So to attend to all those queries from our students, at this time, we're gonna break into breakout room session. So we have 3 rooms. One room will be led by Dr. Op and Dr. Eric, and the other room will be led by Dr. Ndaba. And then myself, I'll be here with our local participant. So there are different topics that we're gonna discuss in the 3 different rooms. Dr. Op will discuss about oxygen delivery device. Dr. Ndaba will discuss about what is the source of oxygen you use at your institution. And here I will discuss about usage and care of pulse oximeter. This breakout session will take 15 minutes. Each group will have a rapporteur when we return back to the main class. We give them 3 to 5 minutes to tell us what was discussed in their breakout session.
Great, thank you, Dr. Papytcho. Before we move into the breakout rooms, I just wanted to show you a little bit of controls once you're there. So in just a few moments, our Echo India team will be moving you into a breakout room. If you need any technical assistance while in your room, there should be a button that says Ask for Help at the top left of your screen. Please feel free to click that. When you're in the room, you can participate by either unmuting or using the chat box. Both are welcome. If your internet is unstable, we recommend you keep your video off. Finally, we will count you down when there's 1 minute left. So please do pay close attention to that, to the timer on your screen. And when you see that there's 1 minute left, please try to wrap up the conversation and get ready to rejoin the main group. So with that, Rahul, if you want to launch the rooms.
Yeah, I'm launching the room.
Okay.
We are back to our main class. Thank you very much for the discussion that you had. We're gonna start sharing what we discussed in our respective group. I don't want to be selfish starting by myself. I can start with Dr. Ndaba's group. They can share with us what they discuss in there. Dr. Ndaba? Dr. Ndaba, check, maybe you are muted.
Oh, okay. Can you hear me?
Now we can hear you.
Okay. So I was asking our group secretary, are you still available? Kindly share with the group just a summary of what we discussed so that we can discuss together.
Oh, yes. Sorry, my mic was muted. I didn't know how to unmute it. Good afternoon, everyone. My name is Sikamo Jackson, and I'm going to give you a summary of what we discussed in our group. So the first question was why is oxygen important in the facilities? And we discussed the answers that we came up with were most of the patients come with conditions that impair oxygenation. And we listed some of those conditions, and especially now that there is the outbreak of coronavirus. So most of the patients are coming with impaired oxygenation to their peripheral tissues. And we also further discussed that regardless of the facility level, oxygen is one of the important drugs that we can have in a facility because of the current situation and most of the conditions that impair oxygenation. Then our second question was the sources of oxygen. So we went on to list some sources of oxygen, which included oxygen cylinders, oxygen concentrators. So the limitation, one of the limitations of oxygen concentrators is that it has a limited flow, which is about 5 to 7 liters. Then we also talked about an Ambu Bag as an oxygen source. Then we also talked about oxygen plant. So an oxygen plant is basically a place in a facility that manufactures oxygen and distributes different parts of the hospital. Say ICU, it distributes to theater, it distributes to the ward. So there's a plant in the hospital, and Dr. Ndaba gave an example of UTH as oxygen an oxygen plant. Then you also talked about a cylinder manifold, which are oxygen cylinders which are placed in series, and this has got an advantage because it avoids accidents that are caused by depleted oxygen in a cylinder. So when one cylinder is done, we just switch on another cylinder. Then the last thing we talked about is at certain condition, oxygen can be stored as liquid, but we didn't finish. That's where our discussion ended. Thank you very much.
Thank you so much.
Thank you very much for that information. Dr. Ndaba, you have something to add?
Yeah, thank you so much. And that's quite a precise summary. I'm impressed with our secretary. Just a small clarification on the Ambu Bag. So one of our participants cited that you can use an Ambu Bag to deliver oxygen in those patients who are not able to breathe on their own. So the clarification there is that an Ambu Bag is just a device that will aid you to deliver oxygen, especially in those patients who are not able to breathe on their own. Maybe they're unconscious or they are paralyzed for one reason or the other. So you can use an Ambu Bag to ventilate them. Not necessarily that it's an oxygen source. So the oxygen sources still remain. You have your concentrator, you can have your cylinders that come in various sizes. You can have a cylinder manifold, like our secretary has explained clearly. You can also have an oxygen plant, which is a large scale way of producing oxygen. And this oxygen is delivered to various areas of the hospital, including wards, emergency areas, ICU, etc., etc. Yeah, thank you so much. Okay,
thank you. Maybe we can also hear from Dr. Eric. He is working in different environment from us. He would have he has another exposure in terms of oxygen sources. I don't know if he has ever faced any challenges with those type of oxygen source. Dr. Eric is practicing in the United States, so the condition of work are different to ours here. Dr. Eric?
Hi there. So our hospital uses the liquid oxygen source, which, for a large hospital, it's a good source of oxygen when you have a lot of ICU beds or just regular floor beds in general that are using oxygen delivery devices. As we've kind of learned from examples in the New York hospitals, when they were overflowed with patients, they actually started running into issues of oxygen supply, because based on the number of patients you have, the number of beds you have, and the amount of flow of oxygen per minute you're using, you can exhaust a hospital's oxygen supply much faster than you're prepared for. So some of these hospitals use an electronic version where they actually generate their own oxygen. A lot of hospitals like ours use the liquid oxygen in big tanks that are stored at the hospital itself.
Okay, thank you very much. If there's any question or any comment, you can drop it into the chat box and then we'll bring it up for discussion. Dr. Ndaba, if we are done with your group, can we move on? Dr. Ndaba, you are muted. Please unmute yourself.
Oh, apologies. Yeah, so I just wanted to quickly emphasize on the first question as to why oxygen is important, especially in the era of COVID. We know that COVID affects primarily your lungs and impairs your ability to oxygenate. So availability of oxygen in our facilities becomes very, very important, regardless of the level of the facility, because the cause of death in these patients who come with severe acute respiratory infections or who develop serious complications such as ARDS is hypoxia. And so early administration of oxygen helps to prevent complications as well as death. Yeah, so oxygen is very, very important and should be available in all health facilities. Thank you, Papytcho.
Thank you, Dr. Dava. Thank you to your group for the nice job. We'll move on into the second group. Dr. Op, are you there?
I'm giving a summary for the group. We are looking at the different oxygen delivery systems, and we looked at when a patient presents to the hospital, we need to really assess on their need for oxygen, and the starting point is always nasal prongs. And we know that nasal prongs are available in different facilities. I think most of our facilities have. So you need to look at different parameters as you assess the patient on their need for oxygen, and you escalate your care based on the delivery devices that you have. So number one, the nasal prongs, they'll give you flow rates of about 1 to about 5 liters per minute. And then you can achieve FiO2s of from about 28% to about 40%. So the initial one, like the nasal prongs and the different masks, are low delivery systems. So from the nasal prongs, you can go to the simple mask. The simple mask, which will give you flows of about 6 to about 10 liters per minute. And you can achieve FiO2s of from as low as 35 to about 60%. So depending on your assessment and of how the patient is performing, you can escalate your oxygen delivery to what are called high flow delivery systems, where we talked about the Venturi masks. Yeah, Venturi masks who have different, they are color coded depending on the flow that they are able to give and the FiO2 that they are able to achieve. This Venturi mask works on the principle of the Venturi principle, where it entrains some amount of air to achieve the FiO2 that you need. And then the Venturi masks, like I mentioned, they are color coded. For instance, if you have the pink, it will give you FiO2s of up to somewhere 40%, and the flows maybe of about 8 liters per minute. So they are color coded, and you can escalate based on the need that the patient has. Then from there, we looked at the non-rebreather mask, which we divided into two. There was the partial and the full non-rebreather. This is just a mask which has got valves and it's got a bag where oxygen goes into the bag. This can achieve FiO2s from about 80 to about 90%, and you can give flows from about 10 liters to about 15 liters. So that's what we looked at. I don't know, I can ask the other members of our team to add or amplify on a few.
Okay, good afternoon, everyone. So we continue to look at how we can transition how we can transition from one oxygen delivery device to another. So basically what stood out was what's very important is we have to look at the clinical signs. These are really going to guide you on the transition from one device to another. So the clinical signs that we really have to look out for are the following. The first was at what saturation is your patient? Is your patient improving on the saturation they are since you connected them to the device? Then you also look at the respiratory rate of the patient. Then the other point was you look at the breathing, the work of breathing that the patient has. Are they laboring to breathe? since you put them on that oxygen device. Then you also have to look at whether your patient is sick, or rather they are improving on the oxygen device. So basically, these are the clinical signs that you're going to look out for. Then another addition was the disadvantage of the nasal oxygen delivery devices was that they usually tend to dry the mucous membrane, and they can cause tissue necrosis or ulcers if we actually use them for a long period of time. Thank you.
Dr. Luimba and Joy, thank you very much for that contribution or reporting back. So basically, we divided oxygen delivery devices into low flow and high flow oxygen delivery devices.
Dr. Op, could you please come close to your mic?
Sorry about that. Dr. Papytcho, we divided oxygen delivery devices into low flow and high flow systems. Then we also looked at the Venturi to be a fixed performance oxygen delivery device because the fraction of inspired oxygen that is delivered is fixed and dependent on the particular device that you're using on. But all in all, that is what we discussed in our breakout session. Thank you.
Thank you very much, both groups, for the wonderful discussion. Now we're gonna invite the secretary from our group to give us a summary of what was our discussion.
Okay, thank you very much. I'm Richard Kahalu, the secretary for the group where the Papytcho is. Yeah, so we were given a task to look at the usage and care of the pulse oximeter. So we discussed on both topics, but I'll refer the care to the video that we earlier looked at. So I'll go straight into the usage. So we discussed that we use pulse oximeters to diagnose patients that come to our facilities with those that come with hypoxia. We're able to detect once they come to the screening rooms, and then we use a pulse oximeter. And then secondly, we use the pulse oximeters to monitor our patients on a daily basis. We also looked at the principles which these pulse oximeters use for them to detect the pulse and the oxygen saturations. So we said the pulse oximeters use the red light and the infrared light. The infrared. The red light moves at 660 nanometers, whilst the infrared moves at 940. That's how come they're able to detect the pulse and the oxygen saturations. So how then do we know that these pulse oximeters are accurate? So the pulse oximeters are supposed to detect the oxygen saturations as close as possible to that if we are going to do the ABGs. Okay, so they're supposed to be calibrated by the manufacturers to the settings that will give us at least 90 or greater than 90% of oxygen. Then we know that this pulse oximeter is giving us the accurate readings. So we further discussed the types of pulse oximeters, where we said we have the conventional type and we have the refractor type. The conventional method uses two detectors. One which will be emitting the light, and the other one will be detecting the light that will go through the either the finger where the pulse oximeter has been put, or the ear probe. Then we have the reflectors, which uses which has also two detectors, the one side which will be emitting, the other side which will be detecting. But in this case, with the reflectors, we discussed that when they reflect, the emitting side reflects the light which hits the bone and scatters the rays, which are then detected by the detecting site, and then it gives us the readings. We also looked at the response time between the conventional method and the reflector method. Okay, so we said the conventional method has the, let's say for instance, if we're using the ear probe takes about 94 seconds for us to detect the drop or the increase in the saturations. Whilst the conventional method will take about 100 seconds to detect any variation in the drop or the rise in the pulse oximeter. We also looked at the limitation in the use of these pulse oximeters. You note that if the patient is having some nail polish on, it will be difficult for the pulse oximeter to read because it's using the infrared to pick the saturations. So there'll be that limitation in the picking of the saturations. Secondly, if the patient has very cold extremities, it is also difficult for the pulse oximeter to pick up the saturation. If we have a patient that is constantly moving, like they're shivering or they're throwing up and about the fingers, it also alters the accuracy of this the pulse oximeter. And also said in patients that are very anemic, it is also difficult for the saturations to be picked by these pulse oximeters. So that is all that we discussed in our group.
Thank you very much, Richard. Just to emphasize on 1 or 2 points that Richard talked about, it's about the accuracy. What we meant to explain there is that when the pulse oximeter is being manufactured, the setting that is put in there is based on the arterial oxygen saturation readings that comes when you get the blood gas analysis. So the settings as it's installed in the bus is that when the readings on the blood saturation it's less than 100, the accuracy becomes a bit more questionable. I mean, less than 90%, it becomes a bit more questionable. But when the readings is higher than or equal to 90%, the readings of the arterial oxygen saturation is above 90 or equal to 90%. It gives you a higher accuracy of the pulse oximeter reading. So if you want to compare the saturation on the pulse oximeter and then you draw blood in the arterial line of the patient for you to go do a blood gas analysis, it will give you a reading which is close to the actual readings on the pulse oximeter. The range of difference there, it's very minimal, it's less than 2%. And then it's higher when it's below 90% of saturation. And the other use of a pulse oximeter is when it comes to condition like ARDS, we said you can use the ratio saturation over FiO2 for you to classify the severity of ARDS. Remember, ideally you should use PA of the PF ratio, which is the P which is from the arterial blood gas analysis. But because most of our facilities in our area do not have blood gas analysis, you can still refer yourself to the pulse oximeter and use the saturation that you are reading and put it on the F. You replace the P by S and then it gives you the SF ratio and help you classify the ARDS in different categories. I hope that is clear. If there's any question, you can still drop it in the chat box and then we'll attend to it. Or if you have any other comment you want to make, you can raise your hand and then we'll give you an opportunity to talk and then we'll hear from you. Dr. Aup or Dr. Ndaba, before we move on.
No comment, Papytcho, at the moment.
Okay, I assume that there's no question, but if you have any question, please drop it in the chat box. We are proceeding with our talk. For now, we're gonna go through the practice change objective. So after this discussion, what do we expect to do, or what do we expect to improve in our everyday practice? I believe that we've managed to understand the use of pulse oximeter during COVID-19 pandemic. And we've understood and recognized a pulse oximeter latency as we explained it. And we are able now to select oxygen delivery devices as per discussion. The use of live box triage tool to select the most appropriate oxygen delivery device that is available to your station. And the use of the live box triage tool to titrate oxygen therapy flows up to or down. And we'll be able to assess our facility for non-invasive oxygen delivery devices. And then we will also assess the type of oxygen supply at our different facilities. And then we are able to go see what is there and then what is not there and where is it located. We'll be able to interpret data obtained using pulse oximeter and understanding the limitation. We'll be able to clean and maintain our pulse oximeter for future use. Yeah. Thank you, Alana. You can move down. Yeah. Before we finalize our today's session, I'll give the floor to Dr. Eric. Maybe could have some more comment to make about the three discussions that we had or any other point during this class session.
Thank you. There is one thing that I always talk to residents about when we're dealing with oxygen therapy, and it's often forgotten, is as much as in medicine we want to provide a therapy or do an intervention.
Eric, are you still there?
Can you hear me? So when I'm talking with residents and we're talking about advancing or providing a higher level of oxygen therapy, I also tell them to keep in mind that hyperoxia is also dangerous. So as important as it is to know when to advance through these algorithms that we're talking about and delivering more oxygen, it's also important to remember in the back of your mind that maintaining someone at 100% of oxygen for long periods of time is also not beneficial. There are some downsides to high oxygen delivery for long periods of time, so hyperoxias can also be dangerous. And knowing when to titrate down from certain oxygen therapies is also important.
Okay, thank you very much. Dr. Hope, any comments?
No comment, Papytcho.
Thank you.